Ladies and gentlemen, there is a great shift in IBD treatment. IBD is a disease known to cause progressive intestinal damage. Early intervention can alter the natural history. However, the heterogeneity in the clinical features and prognosis prevents the use of early and effective strategies. I would like to present a case. This is a lady who came to us after being diagnosed as Crohn's disease for a year, complaining of abdominal pain and weight loss. MRI angiography showed thickening of the ileum, but no strictures. She was not responding to steroid and azathioprine, so we thought to do a capsule. Although colonoscopy didn't show any active disease, the capsule was done and it was stuck for 3 days. And this is the capsule there. So she went for surgery. Laparotomy showed thickened mesentery with whitish exudate and a thickened bowel. And surgery was done and the capsule was retrieved. And this is the surgical specimen. Dr. Ashraf, what do you think? Will you give biologics after the surgery?
So please repeat the question, please.
After doing the surgery, what will be your next step? This patient was not responding to azathioprine, steroids.
This surgery, after this surgery, I have to wait for 8 weeks and start treatment.
Good. We didn't wait long. Coming back to the this is the capsule which is retrieved. Coming back to the specimens, you see the whitish there, caseation from tuberculosis. So we wait for the pathology. It was tuberculosis, and she was treated for TB with antituberculous treatment. This is the whole specimen of tuberculous involvement in the small bowel. So the first diagnosis was wrong. It was not Crohn's. Now, the treatment in the past for inflammatory bowel disease comprising these medications, which we are all using, but some of them are now almost obsolete. The current strategies is early intervention, identify poor prognostic factors, top-down or accelerated step-up approach, target to treat with clinical and patient-reported outcomes, endoscopic and radiological remission, and individualized approach using biomarkers, calprotectin and CRP, and therapeutic drug monitoring. This is the aim of the current treatment in order to reduce intestinal damage, complication, surgery, and hospitalization, and improve the quality of life. Recent studies have determined a number of long-term prognostic factors and developed predictive models which can identify patients who can maximally benefit from early intervention. So when is early intervention? I will come to it. In patients diagnosed with IBD, clinical symptoms are considered to reflect the tip of the iceberg, and symptom-driven management often fails to improve long-term outcome. Lately, therapeutic targets have been shifted from clinical remission to objective parameters such as endoscopic healing. So there is an old concept of treating IBD and thought of IBD as an intermittent flare, treat all the patient the same way, treat to targeting, or reactive management with intermittent monitoring. But the new concept, IBD is a progressive disease, individualized approach according to severity and prognosis. Treat to target is more effective outcome, example, mucosal healing, and proactive management with tight management. We have gone through improved in managing this disease, an individual treatment approach based on timely using non-invasive tests combined with endoscopic and radiological assessment is essential to have better outcome. The management of IBD has greatly improved over the last decade following the introduction of new classes of drugs, particularly biologics, and now have more than biologics. However, early administration and wide use of these drugs can lead to significant health costs nationwide, as well as high incidence of untoward treatment-related adverse effects. So there is a window of opportunity to treat any patient IBD, thus preventing fistula formation, going to surgeon, disability and stricturing. And in cases of Crohn's disease, which is a fluctuating disease, the window of opportunity is the first 2 years of the disease. However, it is not possible for any patient coming to you to exactly tell the number of years this patient has been suffering. Now coming to the treatment. Recently, it's been shown that the combination of infliximab or adalimumab with azathioprine has a better treatment outcome than giving anti-TNF alone. And this improvement in management using biologics should be optimized. Further studies are needed to validate the efficacy of the newly emerging treatment to confirm reducing disability and the need for surgery. There is possibility of giving a step-up approach or top-down approach, and it has been introduced to modify the nature of the disease. Early intervention, there exists a window of opportunity, which I have earlier elucidated, so that we can reduce bowel damage, hospitalization, surgery, and disability. And introducing treatment early will have better mucosal healing, induction of steroid therapy, and preventing hospitalization. Early combined immunosuppression might change the nature and the cause of the disease and prevent complications. There are prognostic predictors: extensive disease, proximal extensive lesion, extraintestinal manifestation, young age of the disease onset, severity of inflammation, and poor response to treatment. And this is an underview of when you have a really complicated case for which we need surgery, young age, male gender, extensive colitis, severe disease activity, high histological inflammation, disease more than 10 years, steroid use, steroid resistance, and the occurrence of primary sclerosing cholangitis. So the background of treating ulcerative colitis with conventional therapy has changed to biological therapies, and according to the new head-to-head therapy, some people say, which is better biologic? Is it better to give infliximab or vidazilimab or ustekinumab? This is the only head-to-head trial which compared adalimumab and vidazilimab and showed the vidazilimab has better clinical response. We need to have more and more studies for combination, for a different response, head-to-head trials between all these biologics, and because we know that every biologic has been studied alone, and there is a significant clinical remission and mucosal healing. Coming to that, the mucosal healing does not exceed 50%. Tofacitinib is an oral drug which improves symptoms, and our previous talk has shown that it reduces stool frequency in ulcerative colitis, rectal bleeding, and number of daily bowel improvement, and I've seen patients with tocilizumab improve within 3 to 4 days after taking this medication. Coming to safety of the drugs, it's very important. Patients who take long-term steroids can develop osteoporosis, high risk of infection, Cushing-like syndrome, cataract, growth retardation, mood changes, diabetes, and cardiovascular complication. I don't think now gastroenterologists use long-term steroid to get these complications. The prognostic factors for Crohn's disease is young age, stricture behavior, penetrating behavior, upper GI Crohn's disease, which is very challenging, perianal disease, which you have seen a talk on it, smoking, weight loss, and number of layers per year. We have elucidated the prognostic predictors. Now comes to treat to target. Various studies have shown that full Mayo score, including the objective endoscopic grades, show a relatively high correlation with the disease activity in ulcerative colitis. While in Crohn's disease, we use Crohn's Disease Activity Index. A meta-analysis of more than 2,000 patients presenting with active colitis has shown that patients achieving mucosal healing at the first endoscopic evaluation demonstrate long-term clinical remission. And this is what we do for any patient coming to the clinic for treatment of Crohn's disease. You have to measure Crohn's disease activity index, and it's easy to get it in the computer. So there are many trials using the Crohn's disease activities and in order to target treatment. Therapeutic strategies, whether to treat early or late, with or without immunosuppression, including combination therapy and relative efficacy and safety of combining immunosuppressants and anti-TNF. The STRIDE program recommends endoscopic healing combined with clinical patient-report outcome as the therapeutic target. However, endoscopic assessment is usually performed prior to initiating modifying treatment, and moreover, the cost factor and patient compliance is a factor. The introducing biologic agents and immunosuppressant has reduced the risk of surgery over time, and despite the proven efficacy of anti-TNF in inducing and maintaining remission, 10 to 20% of patients are refractory to induction therapy. 13% of patients report loss of response during maintenance therapy. Recently, the proactive approach of using drug levels, measuring infliximab at 5 to 10 microgram or adalimumab in an asymptomatic patient show better clinical outcome, including lesser need to IBD-related surgery and hospitalization. It improves the outcome where also observed with the use of adalimumab or other anti-TNF and vidazulumab. What about de-escalating strategy? Healthcare cost associated with IBD has shown increased link significantly rising. Moreover, the risk of TB in endemic areas like in our countries, TB is a thing to think, de novo infection, reactivation like our patient of latent TB in patient receiving anti-TNF. Several long, and we should not rely on tuberculosis TB testing by skin test. We have to go by TB Gold. Several long-term trials have shown the discontinuation of therapy associated with high relapse and suggesting that complete cessation of treatment can be considered and implemented only in selected cases. Using radiology will help, like MRI, angiography, and in predicting and clinical response to anti-TNF. And ultrasound is a new thing. We have to rely on ultrasound. We have to train our gastroenterologists in some countries like Germany, they use ultrasound in any patient who is coming to the office with inflammatory bowel disease. And this is a study we have shown that ultrasound, clinical base point of ultrasound, can play a significant role in guiding therapeutic management and is important to adjunct to routine clinical and laboratory assessment. De-escalating therapy is important, especially in patients who get bone marrow suppression or toxicity from azathioprine, liver toxicity, opportunistic infection, lymphoma, and non-melanemic skin cancer. There's a big problem of infection with IBD, as I've shown you the case with tuberculosis, that as you take more and more medication, combination of infliximab or other immunosuppression will increase the odd ratio of opportunistic infection in patients with IBD. The relapse rate within a year was 50%. However, patients having two risk factors, male genders, elevated leukocyte, elevated CRP, calprotectin, and hemoglobin of less than 15%. Several risk factors have been identified: complicated or perianal Crohn's disease, extensive disease, clinical symptoms, elevated biomarkers, endoscopically documented severe lesions, and monotherapy as predictors of relapse following cessation of therapy. So the new trends in IBD is complex. You have to prognosticate, treat to target, and probably the new drug show better therapeutic efficacy. The oral treatment is coming, and probably in the future, our treatment for IBD we will discard all the injectable forms of treatment, like the way we were treating hepatitis C with pegylated interferon, and we came to oral treatment. One of the oral promising treatment is Janus kinase 3 or tofacitinib, being approved for the use of ulcerative colitis and recently for Crohn's disease. Tofacitinib in ulcerative colitis, the remission rate of up to 36 to 50%, and surgery is not a cure. In Crohn's disease, it may be used to patient with complication and recurrence of following resection will improve after the recurrence. Surgery requirement remains high in biological error. And can we stop a biologic? This is a question mostly asked by the patients who have been taking for a long time anti-TNF or adalimumab, and the answer is no consensus. Involving patient treatment is very important. Patients should know, should be educated, and involvement of patient in treatment decision also can increase the motivation and compliance during treatment. In conclusion, for Crohn's disease, you have to induce rapid response and maintain free steroid remission, achieve and maintain complete mucosal healing, improve the quality of life, avoid complications, prevent disease-related mortality, minimize adverse effects of treatment, avoid treatment-related mortality and morbidity, provide affordable cost for the society, provide acceptable benefit risk, and regarding ulcerative colitis, continue to be a significant burden. Several new therapies with novel mechanism of action are now available. Despite these developments, some challenges still remain. Selecting the right therapy for the right patient as early as possible, identify the predictive biomarkers, and identify the right treatment targeting to avoid complication and restore the quality of life. Thank you.